The Targeted Assessment for Prevention, or TAP strategy, is a framework for quality improvement developed by the Centers for Disease Control and Prevention, the CDC, to use data for action to prevent healthcare-associated infections, or HAIs. The strategy is supported by a suite of tools and resources uniquely designed to address the prevention of catheter-associated urinary tract infections, CAUTI, central line-associated bloodstream infections, CLABSI, and Clostridioides difficile infections, or CDI. In the previous videos, you have seen how the target step identifies facilities and units with the greatest room for reducing the rate of HAIs and achieving hospital safety goals. We've also covered methods and best practices to deploy TAP facility assessments within these targeted locations and how to review results to identify opportunities for improvement. Now, let's take a look at how to prioritize infection prevention gaps identified from the TAP facility assessments and how to implement tailored interventions to address those gaps. This video will focus on practical examples of how to use the information from these assessments to prioritize opportunities for improvement and guide implementation of prevention interventions. As a reminder, a high-level summary of all potential gaps identified from the TAP facility assessments is provided on the first page of the feedback report. After this, partners should review the frequency of responses for each question that was identified as a potential gap. For example, a question may show 45% of respondents answered never, which may vary in interpretation than if the same question had 45% unknown. The two percentages may mean different things depending on the question and the facility. The next helpful step is to determine if a facility has an existing policy in place for this item. If there is a policy or practice currently in place, the gap may be related to awareness, understanding, and/or adherence to the policy. In other words, you determine that yes, you have a policy in place for this item, but staff are reporting unknown, never, or rarely when asked about that policy. This may mean they are not fully aware of the policy or don't understand the policy, which may provide an opportunity to increase education and awareness as an intervention. Alternatively, if there is no existing policy, then perhaps the facility may consider implementing a new policy to address this gap. It may be helpful to perform deeper dives to better understand certain gaps as needed. For example, auditing or observing select practices to gain insight into any barriers or challenges to implementing select policies. Speaking with unit staff and supervisors can also provide more detailed information to help guide next steps. When reviewing results, it is important to consider respondent information, such as role, unit, and unit type. Some of this information is provided in the respondent demographics table of the feedback report, and more detailed information can be explored in the TAP Excel spreadsheet. Being aware of what type of respondents are summarized in the response frequencies is incredibly helpful in understanding gaps because some items may be more relevant for select groups. For example, if you are reviewing results for ancillary staff members, some of the more clinically based questions may not be relevant, and although they may be flagged as potential gaps on the feedback report, they may not be priority items for ancillary staff at your facility. To facilitate this review of results, partners should use the TAP Excel spreadsheet to filter responses as needed to better understand the potential gaps. Steps for filtering data and using the TAP Excel spreadsheets to explore the results are described in detail in our previous video. Facilities may filter the feedback report to view results for just a select group, such as only physician respondents. Alternatively, they may filter to remove select respondents, for example, viewing results for everyone except laboratory and pharmacy personnel. Also described in detail in our previous video, partners can use the TAP assessment results by respondent group Excel spreadsheet to view results for each item across multiple groups simultaneously, helping to determine if a gap is unique to select roles or units. This may also be helpful in identifying a unit that may have highlighted an item as a strength, providing potential insight for interventions among other units that may have identified the same item as a gap. Let's take a closer look at a couple of examples of how we can apply these concepts discussed so far. These examples reference the CDI TAP facility assessment. However, CAUTI and CLABSI results are presented in the same format and the same concepts can be applied. In our first example, we identified that a potential gap presented on the first page of our feedback report related to whether providers avoided testing for CDI cure. To take a closer look, we scroll down to review the response frequencies for this question and identify that 45% of the respondents indicated unknown. This may indicate respondents don't know if providers avoided testing for CDI cure or may be confused with the terminology. As we discussed, we want to consider the respondent roles and units represented in these data and ask ourselves, should the majority of respondents be aware of this concept? If not, then we may want to filter the TAP Excel spreadsheet to subgroups of respondents for which this is relevant, and then review the updated response frequencies. If the updated responses still indicate there is a gap, we can then consider if our facility has a policy in place for limiting the testing for cure of CDI. If so, perhaps education and training may help address this gap. Partners may also perform a deeper dive, such as determining the frequency of which the laboratory receives tests for cure to provide insight into whether inappropriate testing for CDI is occurring. If not, then perhaps the gap is related more to terminology and the understanding of what testing for CDI cure means. Let's now use this same example, but explore how our review and next steps may vary based on a different set of response frequencies filtered to include a subgroup of clinician respondents anticipated to be aware of the terminology. The first page of our feedback report still lists a potential gap relating to testing for CDI cure, but the response frequencies now show a majority of respondents answering never, rarely, and sometimes, with a lot fewer indicating unknown. What this may indicate is that respondents may be aware of what testing for CDI cure is, but they may not be avoiding these tests for cure. If it is determined that your facility does have a policy to ensure appropriate testing for CDI, consider interventions for improving adherence, such as education and training, implementing a testing algorithm, or reviewing the laboratory policy for rejecting inappropriate specimens. As before, it may still be helpful to perform a deeper dive to determine the frequency of which the laboratory receives tests for cure to provide insight into barriers to adherence. If there is no current policy in place, consider establishing and implementing a new policy. In our next example, we have identified a gap related to the rapid implementation of contact precautions at the onset of acute diarrhea. Here, we are going to use the Excel spreadsheet for TAP assessment results by respondent group to further explore this potential gap. As a reminder, this Excel spreadsheet lists each question from the assessments and then summarizes the results for all respondents, and then by individual respondent groups. In this example, we display summary results for Units 1, 2, and 3, and results among just nurses and just physicians. When reviewing this question, we see that it was identified as a potential gap when looking at the results for all respondents, but when looking at this question across our various respondent groups, we see that this was identified as a strength in Unit 2. We may be able to then garner information from Unit 2 about how they are implementing contact precautions to understand what works well, and then perhaps replicate this in other units. Another way we can use this Excel file is to also explore other questions related to the potential gap identified. For example, here we have 3 questions relating to implementation of contact precautions, such as implementation at onset of acute diarrhea and as soon as the C. difficile test is ordered, and whether nurses initiate contact precautions for patients with suspected or confirmed CDI. Similar to the first question, Unit 2 has identified each of these 3 questions as a strength, providing an opportunity to review their practices to identify possible lessons learned and processes to replicate. Now that we have discussed how to identify and interpret gaps based on our TAP facility assessment results, let's explore ways for prioritizing these gaps to guide our next steps. When reviewing and interpreting potential gaps, it's important for facilities to consider contextual factors to better understand what these gaps mean for their facility. These contextual factors may include patient population, unit types, staffing structure, existing HAI workgroups, antibiotic stewardship program, and IT infrastructure. It is also helpful to align this work with other planned or ongoing prevention efforts, such as existing trainings and educational opportunities. The goal is not to duplicate efforts, but to align the TAP strategy with your existing work to maximize prevention resources. For example, perhaps current processes exist that may be adjusted to include new elements based on your findings from the TAP facility assessments. As with all quality improvement work, it is important to recognize capacity and adjust as needed. For example, start small with interventions that are easier to implement or focus on a select unit and then expand interventions as appropriate. When prioritizing gaps, it is helpful to consider the clinical relevancy of the questions and understand which items are recommended versus supplemental strategies. Facilities should ensure recommendations are appropriately implemented before adding supplemental strategies. As with other quality improvement interventions, weighing the feasibility, investment, and projected outcomes can provide insight into how to prioritize efforts. For example, is a proposed intervention easy to implement with a high payoff, or is it difficult to implement with a low payoff? Facilities may also prioritize items based on select respondent groups, such as different roles or units, and the policies and practices that are more critical to them. Let's now look at an example of how we can use the TAP facility assessment results and the summary tools that accompany them to prioritize gaps. In this example, our facility reviewed our overall feedback report and is feeling overwhelmed because there were a lot of gaps highlighted. In reviewing the respondent demographic information, we noticed that 40% of our respondents are classified as an other role, meaning they are not a nurse, nurse assistant, or physician. In addition, these other respondents have an overall score of 17%, which is much lower than the other groups. In this case, we want to take a closer look at others to determine if we should temporarily remove them from our summary report. To be clear, we are not discarding or ignoring their responses, but we may want to temporarily remove them to review the results for our primary patient care staff in an effort to prioritize next steps. We can view information for these other respondents using the input datasheet of our TAP Excel spreadsheet. Here, we will filter the respondent role column to view just the other, please specify responses. In doing this, we see that many are described as pharmacy techs, laboratory staff, admissions clerks, and transporters. While these staff members do play a role in the prevention of CDI and can provide relevant information that we should review, these other groups may not have knowledge of many clinically based practices. To help prioritize immediate next steps, we then decide to filter the respondent role column to temporarily view results for all respondent groups except the other please specify group. Again, this will allow us to review the results for the select respondent roles for which the majority of the assessment items are most relevant. When we then view our feedback report, we see that the assessment overview has updated to now analyze just 84 of our total assessments. The respondent demographics table is also updated, indicating that the majority of the respondents for which we are reviewing the results are patient care staff, with only 2% now listed as other. We can now review the response frequencies for the questions and identify opportunities for improvement among a subset of personnel on which we would like to focus first. Because we filtered the respondents, the number of identified gaps is more manageable, helping to prioritize next steps. Facilities may also perform similar steps to filter for units, temporarily separating select units from the feedback report. For example, if reviewing results for the county facility assessments, consider temporarily removing units if they do not typically care for patients with indwelling urinary catheters. For CLABSI facility assessments, it is helpful to filter the review results for staff who report they are responsible for the care of central venous catheters, as this will help prioritize potential gaps related to the insertion and maintenance of central lines among staff who perform these tasks. While filtering to subgroups is helpful in prioritizing initial next steps, facilities should still review results for each respondent group, as this can garner additional opportunities for improvement and further target prevention efforts. After reviewing and understanding the results from the TAP facility assessments, the next step is to outline priority items and move into the implementation of interventions. There are many quality improvement techniques available to guide facilities in identifying and implementing interventions. One resource available on the TAP website is the TAP Prevention Prioritization Toolkit. This toolkit includes a compilation of templates to help facilities prioritize their infection prevention gaps and develop strategies to implement corresponding interventions. These example templates include a small test of change worksheet based on the Plan, Do, Study, Act cycle that guides teams through planning the test or observation, trying it out on a small scale, analyzing and studying the data, and refining the change as needed. Another example is a strategy grid, which allows for focusing of efforts based on the needs and feasibility of improvement projects. The TAP implementation guides on the TAP website are available for county, CLABSI, and CDI. Each implementation guide includes domains that align with the TAP facility assessments and feedback reports. Each domain includes actionable tools and resources that facilities can use as they implement interventions to address their gaps. These resources include audit checklists, sample policies, comprehensive toolkits, and training tools. Partners may implement select resources as is, or may use them as templates and adapt them to best fit the needs of their program. The Gap Prioritization Worksheet is another optional tool to help facilities interpret and prioritize infection prevention gaps. Facilities may use this worksheet internally as a tool to guide their workgroup through interpreting and prioritizing gaps based on individual facility contextual factors, current policies and practices, and previous and ongoing prevention activities. In addition to using this worksheet internally, facilities may also submit it to CDC for additional assistance in developing prevention strategies. Upon request, CDC will review the completed Gap Prioritization Worksheet and provide tailored feedback to the facility, including example tools, strategies, and resources to help address the gaps identified. Submitting the worksheet to CDC is optional and does not commit facilities to implementing the interventions. It is solely intended to help facilities communicate priority areas so CDC can further tailor technical assistance for their infection prevention efforts. We will take a closer look at the Gap Prioritization Worksheet in a moment, but before we do so, keep in mind that this is a tool intended to help immediate next steps. As such, not all gaps that were highlighted in the feedback report need to be included. The worksheet is intended for gaps that your facility has determined as priority items. The worksheet may also include additional gaps that were not highlighted on the feedback report. You know your facilities best and may be aware of other areas of improvement that were not identified in the assessments. Now let's take a closer look at this worksheet and walk through a couple examples. For each priority item, you will include the gap itself along with your own interpretation of the gap in context of facility policies and practices. You will then assign a priority categorization, such as high, medium, or low priority. It is important to note that the priority categorization is determined by your facility and is a perception of how each item may align with other prevention work. These categories may change over time and may not be based solely on clinical relevancy or assessment results. You will then describe any interventions or prevention efforts specific to this gap that have been implemented within the previous 2 years, which will allow for a better understanding of what has been done previously, so you consider replacing, adjusting, or supplementing them to address this gap. Lastly, you will list any potential ideas for interventions or specific questions you may have for your workgroup or for the subject matter experts at CDC. Now let's look at an example. On our feedback report, we identify a gap regarding nurse and physician champions for CDI prevention activities and review the response frequencies, indicating the majority of respondents said no or unknown. We list this as a gap and explain that we do not have nurse and physician champions for CDI, which is why it was identified among respondents. We classify this item as medium priority and indicate that we have not done anything previously to address this gap. We think it would be most helpful to obtain additional information on how to identify and engage appropriate champions in CDI prevention efforts. With this information, CDC will then be able to provide tools to help guide in the process. In another example, we identified that performing routine audits on the use of personal protective equipment, or PPE, is one of our priority items. When considering our current practices, we describe that we train on PPE, but would like to start conducting audits to ensure staff appropriately select, don, and doff PPE. We classify this as a high priority item because it is something we would like to implement right away. In the past 2 years, we have implemented audits for hand hygiene, but have not done so for PPE use. Our facility would like example audit tools that we can use for all elements of PPE use. When complete, the Gap Prioritization Worksheet may serve as a working document to guide your team in implementing interventions to address the gaps identified. If preferred, completed worksheets may also be emailed to CDC at haiprevention@cdc.gov. Upon receipt, CDC will compile example tools, resources, and strategies for implementation. In addition, CDC subject matter experts are available to provide additional support and guidance as your facility implements interventions to improve infection prevention practices. Facilities also may use this worksheet as part of continued quality improvement efforts, updating and revising the content as they work to implement interventions. The TAP strategy tools and technical assistance are available to partners across the nation as we work together to improve patient care and reduce healthcare-associated infections. For a more in-depth review of the TAP tools and guidance for implementing each component of the TAP strategy, please see the additional videos available at the TAP website. For questions and requests for technical assistance, please email CDC at haiprevention@cdc.gov.